What lessons have you learned from building the regional tobacco quitline model, and how can this be scaled or replicated for other public health interventions?
Tobacco use is possibly one of the legal addictions that causes the maximum amount of harm in terms of both mortality as well as morbidity.
What messages would you share with the next generation of mental health professionals in India and worldwide, especially as we move toward the World Health Assembly's vision of one word for health? How can they contribute to a future where mental health is central to global health and equity?
From a non-communicable disease. And people with physical problems, diabetes, hypertension, cardiac disease, respiratory disease, are much more likely to have mental health problems, which can influence their recovery and their long-term prognosis.
Dr. Pratima Murthy is one of the most prominent figures leading the forefront of mental health interventions in India. Currently, she is serving as the Director and Senior Professor of Psychiatry at the National Institute of Mental Health and Neurosciences, Bangalore, India. With over 30 years of clinical, academic, and policy level experience, and as the former head of the Center for Addiction Medicine at the National Institute of Mental Health and Neurosciences, she has played a pivotal role in scaling up addiction services nationally. Her work exemplifies the fusion of science, compassion, and public health leadership, and her voice continues to influence national strategy and global discourse on mental well-being. Welcome to this interview, Dr. Pratima Murthy. It is an honor and a pleasure to have you with us today.
Thank you, Pietro. Thank you for having me on this show.
Dr. Murthy, tobacco cessation interventions have been a major area of your research expertise. What lessons have you learned from building the regional tobacco quitline model, and how can this be scaled or replicated for other public health interventions?
So, Pietro, tobacco use is possibly one of the legal addictions that causes the maximum amount of harm in terms of both mortality as well as morbidity. And sadly enough, particularly in low and middle income countries, combined with other nutritional infection and other problems, these impacts are huge. And unfortunately, all over the world, it's well known that very few people try to quit once they've become dependent, because nicotine in tobacco is the most addictive substance that we know of. And even amongst those who want to quit, most of them kind of go and tend to relapse. In low and middle income countries, in addition to smoking tobacco, we also have the problem of smokeless tobacco. And all of us know that smokeless tobacco is associated with so many different oral cancers, for example. And therefore, we felt the need to educate the healthcare providers to train people in supporting people to quit tobacco. Over the last couple of decades, we've learned that psychosocial counseling, motivating people to quit, giving them either nicotine replacement or non-nicotine treatment to help them quit helps. But not all people can access healthcare services. So it's very important to reach people. And what better way than telephonic services? And that led to the development of the quitline in our country. I think there are 2 or 3 messages here. One is for people who don't start using tobacco, never to use tobacco as a way of dealing with stress or a way of relaxing. The second thing is to stop it before it becomes too much of an addiction. And the third thing, if they're addicted, is to get help. And certainly the quitline, what is called the M cessation model, as well as tobacco cessation clinics, have helped people in this journey. And I think one of the greatest successes is that along with tobacco cessation support, as well as policies to regulate tobacco use, particularly in public spaces, we've had a 7% reduction in the use of tobacco in India. And I think the journey has to continue to make more and more people tobacco free.
That's an impressive project. You have contributed to developing several national treatment strategies and psychosocial intervention guidelines for individuals struggling with substance use disorder. What core challenges have you encountered while ensuring these guidelines are adopted and implemented at the grassroots level?
People ask about the use of alcohol, tobacco, and other drugs. Sometimes it becomes a very moral issue. They're very hesitant to ask, particularly women or maybe adolescents. I think a lot of people are not aware that addiction or substance dependence is a medical problem, is a biopsychosocial problem, and therefore they don't take help for it. So one of the things is also the biggest challenge is to make people aware of the nature of this problem, how addiction is actually a brain disorder at the end of the day. And when they want to stop because of withdrawal symptoms, they're not able to stop. So I think first is the awareness building. That is a big, in some ways, a barrier. The second, of course, are the societal stigma around reporting these substances. And to me, for example, one of the successes is when people come forward, say they have a problem and want to take help. So much so that we've had several physicians who themselves had a substance use problem also coming forward and getting help. To me, that is really, an indication that substance use can affect anybody, and getting help is very important. The third thing is working with families, because again, addiction being stigmatizing, a lot of family members don't want to talk about it. They want to hide the problems of addiction. So getting them engaged is also very, very important. The fourth thing is really the availability of treatment services close to where people are. And treatment is not just pharmacological treatment, it is also psychosocial treatment. And that one of the exciting things that we, for example, did was have follow-up counselors, so who kind of, after treatment would follow up our patients. And if they didn't come for follow-up, would actually call them up. So the follow-up counselors would actually tell them that it's okay, if they slipped, but it's important to kind of come and get back onto treatment and get back on their feet again. And finally, I just wanted to say that substance use is linked to a lot of communicable as well as non-communicable disorders. So really within those programs, to make sure that the prevention of substance use and its treatment is also taken care of is very important. Some of the programs tend to be very vertical and don't take care of these simple things that need to be done. So I think sensitizing people working in that to also take cognizance of both substance use, comorbid mental health problems, and really look at health holistically is very important. And I think that's really very important to have in terms of policy and programs in a lot of countries.
Thank you for sharing. As you said, it sounds like a very holistic approach. You have also highlighted how advances in genetics and brain imaging can aid mental health treatment. Within the World Health Assembly's One World for Health framework, how can we ensure that such high-end innovations are equitably accessible across countries with diverse healthcare capacities?
So I think one of the things that has been understood about addiction in the last few decades is, number one, that substances are pharmacological agents which act on different parts of the brain, which act on the reward circuit. We know the mechanisms for dependence, for withdrawal, and so on. And that helps us to overcome some of the stigma associated with a very moralistic view of substance use. And I think that also helps families accept substance use as something that is determined by genetic causes, by possibly, inherent biological causes. But of course, there is also an interaction with the environment outside. So understanding the host and the environment helps really to see how you can mitigate that. Now, when it comes to all countries adopting practices, there may be some practices in terms of substance use prevention that can be universal in the way it's looked at. For example, denormalizing substance use, teaching people other ways of dealing with stress, for example, or finding other ways of relaxing, especially young people, making sure they don't start substance use at a very young age. recognizing people who might have a vulnerability because they had a family history of addiction or because they have other mental health problems. All of these can be done with not too much resource, not very intensive, resources. At the same time, medications which are cost effective, there is enough evidence to suggest that there are cost effective medications that are available, that you can care, that you can train primary healthcare staff in motivating people to change and supporting them in the change. I think all of these are very, very important aspects that different countries can take. And I think that's been one of the objectives of the World Health Organization, to really transmit this knowledge to all countries to make sure. And I think when you talk about equitability, I think a right to treatment is possibly one of the most equitable things that you need to ensure, irrespective of where the person is. And that's where we've tried to extend some of this empirical evidence.
Great work explaining how this works. Now, what messages would you share with the next generation of mental health professionals in India and worldwide, especially as we move toward the World Health Assembly's vision of one word for health? How can they contribute to a future where mental health is central to global health and equity?
From a non-communicable disease. And people with physical problems, diabetes, hypertension, cardiac disease, respiratory disease, are much more likely to have mental health problems, which can influence their recovery and their long-term prognosis. So I think this ability to look at it holistically, to also focus on mental health promotion. So at NIMHANS, for example, where I work, we have a department of integrative medicine, which looks, for example, at practicing yoga, teaching people how to do simple yogic exercises as a way of relaxing. We have a department of clinical psychology, which tells people, how to be mindful, how to relax, how to deal with stress, and how to cope better, how to develop resilience. So you start off with interventions like that, and then go on to develop more specific interventions aimed at different kinds of mental disorders, as well as the pharmacological treatments, particularly for severe mental illnesses. But as I mentioned earlier, unlike other acute health conditions, many mental disorders tend to be chronic, and therefore people need longitudinal support. So really developing a life course perspective to various kinds of mental disorders, trying to identify from pregnant women to young children, to adolescents, to working adults, to the elderly, and developing programs that in some ways may be generic to a particular group, but also address the different phases of life, gender related issues, work related issues, marginalization. All of that becomes very important to make sure that nobody kind of is left out of the net. It's a quite a large ask, but I think working at it gradually and getting people to really look at the continuum of care, from primary health care to specialized and tertiary care, is really the way forward. And of course, we do talk about task sharing, making sure that somebody is out there to provide that kind of support at different levels of complexity within healthcare systems is possibly the way to go forward.
Thank you for that message and for reminding us of how important integrated healthcare services are. Dr. Pratima Murthy, thank you for all your outstanding contributions to the field of tobacco cessation, substance use, and psychiatric disorders at the local and global level. We wish you continued success in all your future endeavors. Thank you very much.
Thank you very much, Pietro.